Hello, today I'll be discussing the condition of Crohn's disease. I would like to begin by acknowledging the traditional owners of country throughout Australia and the land upon which I stand today. I would also like to extend my respects to elders past, present, and emerging. Normal digestive tract pathology. So the gastrointestinal tract is a complex collection of organs functioning collaboratively to perform essential physiological functions such as chemical and mechanical digestion of food products, absorption of nutrients, secretion of water and digestive enzymes, and excretion of metabolic waste products from the body to maintain a homeostatic environment. These processes begin with the oral cavity, with the teeth performing mechanical digestion through chewing, whilst the tongue assists with compression and manipulation of food products, and the salivary glands, comprised of the parotid, sublingual and mandibular glands, produce enzyme-rich saliva for food breakdown and lubrication of food products for transition down the gastrointestinal tract. Food then travels down the pharynx, a direct passageway to the esophagus, where waves of muscular contraction known as peristalsis occurs, shifting the food to the stomach. In the stomach, food is further mechanically and chemically digested by churning food product with gastric enzymes and stomach acid before it moves to the small intestine. The small intestine, containing the duodenum, jejunum, and ileum, is where 90% of nutrient absorption occurs. The duodenum receives chyme from the stomach and digestive materials from accessory organs, whilst the jejunum and ileum continue chemical digestion and absorption of food products. The ileocecal valve then allows materials to relocate into the large intestine, comprised of the cecum, ascending colon, transverse colon, descending colon, and sigmoid colon, where absorption of water and electrolytes occurred, creating fecal matter, which then passes through the anal canal. Accessory organs involved in this process include the liver, which produces bile and aids in fat digestion, the gallbladder, which stores and concentrates bile, and the pancreas, which secretes digestive enzymes and hormones to aid in digestion. Pathophysiology. Crohn's disease is an immune-mediated inflammatory bowel disease affecting organs in the gastrointestinal tract from the oral cavity to the anal tract. It is predicted to be the consequence of imbalanced pro-inflammatory and anti-inflammatory mediators in combination with environmental factors, genetic susceptibility, and intestinal microbiome dysfunction characterized by abnormal immune responses to gastrointestinal digestive bacteria. At a cellular level, susceptible individuals experience genetic mutations such as NOD2 and CARD15, which alters immune recognition of bacteria and mucosal dysfunction in the gastrointestinal tract. This further leads to overactivation of T cells, causing inappropriate attacks to the stomach lining, and failure to suppress excess immune responses, causing chronic tissue damage. These individuals experience decreased macrophage and dendritic cell ability, in which the cells are unable to respond to the pattern recognition receptors, and decreased autophagy, meaning cells are unable to degrade and remove damaged intracellular bacteria, both further contributing to chronic inflammation. These mechanisms lead to immune system overreaction associated with transmural inflammation, including submucosal layers, granuloma formation and deep cobblestone ulcers, fistula formation and narrowing of the tract. These pathophysiology changes impair nutrient absorption, damage the mucosal barrier and overall structure of the gastrointestinal tract, and thicken bowel walls that are highly susceptible to obstructions, perforation, and abscesses. Signs and symptoms. In Crohn's disease, key clinical manifestations such as hyperactive bowel sounds, abdominal pain, and vomiting are caused by the signature chronic inflammation and narrowing of the gastrointestinal tract, known as strictures. Hyperactive bowel sounds occur due to strictures of the bowel increasing intestinal workload and creating more forceful contractions at a higher frequency to move food products through these narrowed segments. Similarly, vomiting may also result from inflammatory strictures of the gastrointestinal tract obstructing food from moving freely, potentially causing obstruction of the bowel and, in extreme cases, fecal vomit. Abdominal pain, which is typically the primary complaint, occurs as chronic inflammation and strictures trigger pain receptors and alter muscular function, resulting in sharp cramping sensations. Diarrhea is another common symptom, with chronic inflammation of the tract lining and mucosa causing intestinal injury, disrupting fluid absorption and leading to the release of watery stool. Systemic signs such as tachycardia and increased risk of arrhythmias is associated with Crohn's disease, with chronic inflammation leading to damage and narrowing of blood vessels, and autonomic dysfunction leading to unregulated heart rate. Hypertension may also develop as a consequence of autonomic dysfunction or due to fluid loss from vomiting and diarrhea, inducing a hypovolemic state. In severe cases, Crohn's disease may affect accessory organs, specifically the liver, with inflammation to this organ causing scarring and blockages of bile ducts, resulting in a jaundiced appearance. Paramedic practice. Understanding pathophysiology and clinical manifestations of Crohn's disease is crucial for paramedic practice and informs paramedic diagnosis, clinical decision-making, and pre-hospital management. Whilst paramedics in the pre-hospital environment can't definitively diagnose due to limited laboratories and medical imaging access, it is essential that they can recognise key symptoms such as abdominal pain, distension and tenderness, vomiting and diarrhea, signs of infection and gastrointestinal bleeding, and how to treat these appropriately. A strong understanding of Crohn's disease pathophysiology and recognising the symptoms allows targeted history taking and relevant vital sign assessments such as heart rate, blood pressure, respiratory rate, temperature, and oxygen saturations to establish a baseline state and reveal any deterioration. Recognising the effects of Crohn's disease on the gastrointestinal tract also informs paramedics to perform a thorough physical assessment with inspection, palpation, and auscultation for bowel sounds, and allows for the administration of fluids and appropriate pain relief, with a focus on avoiding non-steroidal anti-inflammatory drugs to prevent further aggravation of the exacerbation of disease or causing additional gastrointestinal injury. Ultimately, this pathophysiology understanding allows for recognition of high-risk patients in need of rapid intervention and transport to hospital. Diagnosis. A diagnosis of Crohn's disease requires a multimodal approach involving analysis of pathology specimens, medical diagnostic imaging, and medical endoscopic procedures. The self-collection of feces and urinary samples and phlebotomy-collected blood samples are typically considered the first step of diagnosis, as although these tests are incapable of definitively diagnosing Crohn's disease, they can be highly indicative. Fecal calprotectin is the predominant stool test recommended for suspected Crohn's disease, with elevated levels of this protein, which is produced by neutrophils and monocytes, indicating intestinal inflammation due to migration of these immune cells to intestinal mucosa. An MCNS, microscopy, culture, and sensitivities, and a Clostridium difficile feces test may also be requested to identify other bacteria, viruses, or parasites which may be closely mimicking Crohn's disease. A urinalysis dipstick urine test may also provide evidence suggestive of Crohn's disease, as the presence of bacteria and protein in the urine, along with elevated white blood cell counts and intestinal fatty acid binding protein biomarkers, are known complications which indicate intestinal damage. Phlebotomy collected blood samples may also be suggestive through tests including complete blood examinations, C-reactive protein, and ESR test. Complete blood protein is decreased red blood cells indicating anemia, whilst platelet and white blood cell counts indicate the body's immune system is actively responding to the inflammation if increased. C-reactive protein is an acute phase protein produced by the liver, typically in response to the release of pro-inflammatory cytokine interleukin 6, which is excreted during bodily inflammation. In Crohn's disease, this protein is elevated due to inflammation of the gastrointestinal tract. And ESR refers to the speed at which red blood cells settle within the bottom of a test tube in an anticoagulated blood. A quicker rate indicates infection or inflammation within the body, specifically intestinal inflammation in the case of Crohn's disease. Finally, diagnostic imaging and endoscopy procedures play a critical role in diagnosing Crohn's disease. MRE scans analyse magnetic fields and radio waves in combination with a contrast agent to produce high-resolution images of the intestines and surrounding tissues, identifying the presence of any inflammation, structural changes, or fistulas. CTE scans are specialised CT scans also involving contrast agents, which illuminate any inflammation, strictures, or abscesses within the small intestine. And endoscopy procedures provide direct visualization of the inflammation, mucosal deformities, strictures, and ulcers through self-ingestion or surgical insertion of a minute camera into the esophagus, stomach, or small and large intestines. This procedure also allows clinicians to collect biopsy tissue samples through which they can analyse the extent and severity of the condition.